This is Dr. Manogaran, Professor and Head of the Department of DVL, Sree Balaji Medical College, Chennai. Today I am going to talk on the bacterial infection. In that we have specific learning and objective, etiology and clinical features, investigation and treatment of various bacterial infections of the skin. Pyodermas are broadly classified into primary one and the secondary pyoderma. Primary pyoderma is due to direct invasion without any damage to the skin. Another, we have superficial type of pyoderma. We have folliculitis, impetigo, and a deep infection we have psychosis barbae, furuncle, carbuncle, ecthyema, cellulitis, erysipelas, paronychia. The most common organisms which are being isolated from this primary pyoderma, mostly Staphylococcus aureus and Streptococcus pyogenes. We have secondary pyoderma due to damaged skin as a result of trauma, pre-existing skin disorders like eczema, scabies. As a result of the secondary pyoderma will arise. Under secondary pyoderma, we have secondary folliculitis, acne conglobata, hidradenitis suppurativa, dissected cellulitis of scalp. This acne conglobata, hidradenitis suppurativa, dissected cellulitis of scalp, we call it as follicular occlusion triad. When there is presence of pilonidal sinus, we call it as follicular occlusion tetrad. When there is presence of pyoderma gangrenosum, we call it as follicular occlusion pentad. Then we have acne cularis nuchae, especially over the neck. Pyoderma vegetans, it's a vegetative growth over the axilla and groin. Infected eczemas, intertrigo, it is nothing but inflammation of two opposing skin surface. Infected ulcer, we have tropical ulcer and cutaneous involvement in some of the systemic bacterial infection also. Impetigo, it is one of the common bacterial infection commonly seen in children, especially school-going children, young adults. The meaning of impetigo is to attack. So this impetigo, the common provocative factors, overcrowding, malnutrition, poor hygiene, trauma. So these are important precipitating factors for impetigo. The incubation period is somewhere around 1 to 3 days. It is broadly classified into bullous impetigo and non-bullous impetigo. On the right side, we have a classical picture of the bullous impetigo. The bullous impetigo caused by Staphylococcus aureus exclusively, especially by the toxin called exfoliatin. It is not due to direct invasion by the toxin. Usually seen in neonates and infants, presence with the flaccid bulla lasting for 2 to 3 days, and there is peripheral extension always with the central clearing. That's the clinical hallmark of bullous impetigo. And since the localized form we call it bullous impetigo, the same process, if it occurs in an extensive way, we call it staphylococcal scalded skin syndrome or Ritter's disease. Non-bullous impetigo is otherwise called impetigo contagious of Tilbury pox. It is caused by Staphylococcus aureus as well as Streptococcus pyogenes. It affects mainly school-going children, and there is always a predilection for perioral and perinasal area. Presence with the thin-walled pustule, that is supposed to be the primary skin lesion in non-bullous impetigo. It gets ruptured very soon, results in honey-colored crust and extension peripherally without any central clearing. So that's the difference between bullous and non-bullous impetigo. It is associated with regional lymphadenopathy. Since it is caused by streptococcus, there is every chances of infection like glomerular nephritis. So these are the difference between bullous impetigo and non-bullous impetigo. The bullous impetigo, it is caused exclusively by Staphylococcus aureus. Non-bullous impetigo caused by Staphylococcus aureus and Streptococcus pyogenes. Bullous impetigo occurs in neonates and infants. Non-bullous impetigo occurs mainly in school-going children. Morphologically, bullous impetigo starts with a placid bulla, non-bullous impetigo with the pustule and with the typical honey-colored crust. And the site is, and then this evolution, there is peripheral extension with the central clearing in the case of bullous impetigo. Non-bullous impetigo extends peripherally without central clearing. Lymphadenopathy is very rare in the case of bullous impetigo. It is a common find in the case of non-bullous impetigo. Complications like staphylococcal scalded skin syndrome in the case of bullous impetigo, non-bullous impetigo, post-streptococcal glomerular nephritis is the important complication. Folliculitis. What is folliculitis? It's inflammation of hair follicles called folliculitis. It is broadly classified into superficial folliculitis and deep folliculitis. The superficial folliculitis, that's involvement of the mouth of the hair follicle or the follicular ostium. Under superficial folliculitis, we have Bocard's impetigo occurs for the scalp margin and dermatitis coronis pustulosa et atropicans. These are the two types of superficial folliculitis. Under deep folliculitis, we have furuncle, carbuncle, psychosis barbae. So there is involvement of the deeper part of the hair follicle, especially the lower portion, and the isthmus getting involved in the case of furuncle, carbuncle, and psychosis barbae. What is erythrasma? Erythrasma is a bacterial infection caused by Corynebacterium minutissima. It involves mainly the flexural areas, especially the axilla, groin, submammary region, and interdistal cleft. And important precipitating factors are obesity, diabetes mellitus, and excessive sweating. It is asymptomatic most of the time, clinically characterized by erythematous and brownish patches over the axilla and groin with the presence of satellite skin lesion. It is bilateral symmetrical always. The differential diagnosis is seborrheic or the flexural psoriasis, then the dermatophytosis, pityriasis versicolor, especially the chromic type of pityriasis versicolor, and candidiasis. In the case of erythrasma, the axillary vault involvement is a common finding and is a constant finding. That is the only point that can be differentiated from the other skin disorders, which I mentioned as the differential diagnosis. So, when you do the Wood's examination, there is a typical coral red fluorescence. It is due to the liberation of coproporphyrin 3 by the bacteria. So, you can see in the picture that fluorescence you can see. And regarding the treatment, topical keratolytics like topical Whitfield ointment, topical clindamycin, topical mupirocin, topical fusidic acid, and systemically erythromycin is the drug of choice. Easy to remember, erythrasma, erythromycin for a period of 7 to 10 days. And tetracycline is the other option. Psychosis barbae, it is nothing to do with the fungal infection. It is a bacterial infection caused by Staphylococcus. What is the meaning of psychosis? It resembles the cut section of ripe fig fruit, also known as psychosis vulgaris barbarus H, usually seen in male population, always seen in male population, caused by Staphylococcus aureus, clinically characterized by multiple erythematous follicular papules and pustule with the perifollicular erythema. It is being centered by hair follicle, and it is discrete or coalesced to form multiple pustule, and it is mainly seen over the beard region and over the mustache region. The closest differential diagnosis for psychosis barbae is Tinea barbae. In the case of Tinea barbae, since it is caused by dermatophytosis, it is a well-defined, a block with a well-defined border. So that is always seen in the case of Tinea barbae. So the variant of psychosis barbae is your lupoid psychosis. Here there is a destruction of the hair follicle with the scarring. That is the hallmark of lupoid psychosis with the presence of multiple papules and pustule at the advancing margin. The differential diagnosis of pseudofolliculitis of the beard, Tinea barbae, and lupus vulgaris. Pseudofolliculitis is a beard due to inversion of the hair follicle as a result of shaving. Tinea barbae is a dermatophytic infection, and lupus vulgaris, it is one of the common cutaneous tuberculosis. Treatment for psychosis barbe, topical antibiotic like mepirocin, fusidic acid, systemically a course of doxycycline, erythromycin. Resistant cases can be managed by rifamycin, and then laser air removal, photodynamic therapy. So these are the options for resistant type of psychosis barbe. Furuncle, it is one of the deep-seated folliculitis, wherein there is involvement of the lower part of the hair follicle, and it is also known as boil or abscess. And the lower part of the hair follicle is filled with pus, and this undergoes suppuration and abscess formation, results in periportitis staphylogenes, and heals with scarring always. It is a deep-seated tender nodule or the air-bearing regions, and there is a discharge of pus when it undergoes suppuration, heals with scarring. The important predisposing factors are diabetes mellitus. When it is recurrent, we should rule out diabetes mellitus, and also HIV and prolonged immunosuppressive drugs like steroid. Treatment, most of the time, you should give systemic antibiotic like erythromycin, azithromycin, and sometimes this clindamycin are found to be useful. And topically, also when there is evidence of abscess, topical antibiotic like mupirocin and fusidic acid. Carbuncle, it is similar to furuncle. In furuncle, single hair follicle getting involved, whereas in carbuncle, contiguous hair follicle getting involved. It is one of the important cutaneous marker of diabetes mellitus. The meaning of carbuncle is pyrrole or charcoal. It is caused by Staphylococcus aureus, and the site usually over the back with the multiple sinuses discharging purulent material. That is one of the important clinical hallmark of carbuncle. The important predisposing factor is diabetes mellitus and other immunocompromised state. The common site is over the nape of the neck. So you can see a picture with the multiple sinuses. And the treatment is going to be incision and drainage under diabetic control, and oral as well as topical antibiotic. Ecthyma, it is one of the deep-seated kind of impetigo, deep-seated variant of impetigo caused by Staphylococcus aureus, Streptococcus pyogenes, Pseudomonas aeruginosa, Staphylococcus aureus. So these are the causative organism. And this ecthyma starts as a pustule with the adherent crust. When you try to remove the adherent crust, you can see the punctured out ulcer. It is commonly seen on the buttocks, thighs, and legs. And this ecthyma, it heals always with the scarring. That is the clinical difference between ecthyma and impetigo. Impetigo doesn't heal with the scarring, whereas ecthyma heals with the scarring always. The differential diagnosis of pyoderma gangrenosum, it is a Schwarzman phenomenon. It is one of the neutrophilic dermatosis, and this starts as a furunculated nodule with ulceration with the undermined edge, heals with the cribriform scar. And ecthyma gangrenosum is nothing but this Pseudomonas septicemia. And culture, regarding investigation, culture can be done. So depending upon the culture sensitivity, most of the time they will respond with the topical antibiotic and course of systemic antibiotic like erythromycin, cloxacillin, flucloxacillin. So these are the treatment options for your ecthyma. Cellulitis, it is one of the deep-seated infection of the subcutaneous tissue caused by streptococcus most of the time. And the four cardinal signs of inflammation like erythema, warmth, pain, and swelling. This will be present always, the signs of inflammation, and starts as a erythematous tender swelling with ill-defined border. And sometimes when the infection is very severe, there is appearance of vesicle, ulceration, pustules, and necrosis on the surface of the skin lesion. Patient will be very toxic with constitutional symptoms and enlargement of regional lymph nodes, lymphangitis, and lymphadenitis. And since it is caused by streptococcus, the chances of acute glomerulonephritis is quite possible. And subacute bacterial endocarditis, septicemia is one of the important complications with cellulitis. That is why whenever a patient comes with the cellulitis, you should always rule out the septicemia. You should ask for blood culture. And regarding the treatment, systemic antibiotic is always the treatment of choice, like cloxacillin, flucloxacillin. And then, of course, the topical antibiotic also is one of the options. So systemic antibiotic has to be given. Erysipelas, it is another deep-seated bacterial infection caused by Streptococcus. It is otherwise called Saint Anthony's fire, and we should know how to differentiate this erysipelas and cellulitis. In erysipelas, the dermis will be involved, especially the deeper part of the dermis will be involved. Whereas in the case of cellulitis, the subcutaneous tissue is the primary site of involvement. In the case of cellulitis, the lesion will have a well-defined border and well-defined edge, and it is commonly seen over the face. It occurs following trivial trauma, and when there's involvement of ear, it is always erysipelas. We call it as Milan's ears, and because the subcutaneous tissue absent in the case of earlobe, so it is only erysipelas. If erysipelas, if it is occurs on the central part of the face, that is, it is supposed to be the dangerous area. Chances of cavernous sinus thrombosis, brain abscess is likely to occur, and this it will have a sudden onset with a well-defined margin. Sometimes, very rarely, with the presence of pustules, vesicles on the surface. When compared to cellulitis, patient will not be so toxic, and here also chances of septicemia are said to be reported. The treatment is a course of antibiotic, oral antibiotic like cloxacillin, flucloxacillin. On the right side, we have a picture of erysipelas. We can see the border, well-defined border. Next slide. Necrotizing fasciitis is a rapidly progressive necrosis of subcutaneous tissue caused by caused by Streptococcus mainly. There are two types. One is polymicrobial type, the other one is monomicrobial type. Clinically, it begins with extensive tenderness, erythema, swelling, and skin will be looking shiny and tense. And on the surface, we can see sometimes a purple colored discoloration will be present. It is due to necrosis of the skin, including the subcutaneous tissue with a malodor. And sometimes when there's involvement of cutaneous nerve, so there is chances of anesthesia will be present with severe constitutional symptoms like fever. And this necrotizing fasciitis is one of the Schwarzman phenomenon. And chances of pointless gangrene is possible when there's involvement of perineum and the genitalia. The treatment going to be surgical wound debridement, that's very important, and a course of broad spectrum antibiotic. And this necrotizing fasciitis is supposed to be one of the dermatological emergency. I have discussed the various types of pyodermas, right from impetigo, folliculitis, cellulitis, erysipelas, and then blistering digital dactylitis, erythrasma, keratolysis punctata. Regarding the investigation, clinical features, investigation, and the treatment aspect, preventive aspect of various pyodermas.